Hello students, I hope you are having a great day. Let me introduce myself. I am Dr. A. Bala. I am working as a teaching faculty assistant professor in biochemistry in Government Kilpatrick Medical College, Chennai. And I am also a practicing consultant biochemist with a standalone laboratory and a multi-specialty hospital. And I am a special consultant to a pharmaceutical company which is involved in abbreviated new drug designing. And my keen interest is in teaching and research. I have been teaching students for preparing MDMS entrance examinations for the last 5 years. I'm associated with the coaching institute for next NEET PG entrance concept, and I have a deep interest in research, and I'm having 10 papers in international and national peer-reviewed journals to my credit. And with this, having introduced myself, I just want to get you into a very interesting topic. This is a very short series video sessions I'm recording for you. It is one of the very important and evolving topic of today. The topic which I'm going to deal is lipid metabolism. In specific, it is lipoprotein related, LDL receptor regulation and dysfunctional lipidology. That is what I'm going to share and discuss with you for the next few minutes. And let us start it. So you have our links here, and that is going to be KONCPT NEXT is the group in which, along with biochemistry, you have all the 19 subjects to learn, and the group is available at Telegram. You have the YouTube channel, and my Telegram channel and YouTube channel links I will be posting along with the video in the comment section, so you can join it. It's one of the best groups. You have to be, and you must be in if you want to really take your entrance examination preparation or your knowledge enhancement to a next different level. Okay, so now, to be concise, this is the way in which cholesterol receptors function, or LDL in particular. We are more concerned about LDL rather than the other lipoproteins, which in order to address the issue of LDL uptake and their metabolism, we need to know how the cellular mechanism of functioning of LDL receptors is happening. So let me tell you a brief clear point. Number one, always suppose this is a cell. Remember, cholesterol or LDL goes in and it is stored. It is stored and then it is effluxed. These are the only three mechanisms here involved. It enters in, it is stored, and it goes out. Okay, and this storage form can be two forms. It is free cholesterol or cholesterol ester. It is free cholesterol or cholesterol ester. Now, considering this backdrop, we will take it step by step. We'll take it step by step. Okay. Let us assume this is the cell and LDL has to enter. Now, there are three mechanisms by which LDL can occur. Three mechanisms by which LDL can enter. Number one, the first mechanism is LDL can enter itself as free cholesterol. LDL can enter itself as free cholesterol. Number two and number three, both involve LDL entry as cholesterol ester, but through different receptors. The first receptors will be LDL or ApoB receptors. The second receptors will be scavenger receptors. Scavenger receptors. Okay, so these are the three mechanisms by which LDL can enter into the cell. Okay, when it enters into the cell via this LDL receptors, hope you all know the Frederickson's classification. The defect in LDL receptors belongs to type 2 lipoproteinemia, hyperbeta lipoproteinemia, familial hypercholesterolemia. Okay, LDL receptor defect. Okay, so this is like a pit. This is like a pit. And basically the whole process is about endocytosis. Probably you know that cellular intake is divided into phagocytosis. The size is bigger, more than 5.5 microns, it's phagocytosis. If it's less than 0.5 microns, it's going to be pinocytosis. And the LDL metabolism is involved about the pinocytosis. Okay. Now these pits are coated by a separate material called as clathrin. So basically, the intake is via the clathrin coated pits. Clathrin coated pits. Now that LDL has come inside, LDL has come inside. What are the two fates? Now LDL can get stored, or LDL can go as efflux. This transport or efflux of LDL from the peripheral tissues outside, from the peripheral tissues, the LDL is taken back to the liver. This is called as reverse cholesterol transport. Though I am not going to deal it today, it is mediated by another lipoprotein called as HDL. I am only going to stick with LDL today. Okay. So here LDL is stored. I said again, I have already told you it is stored as either free cholesterol or it is converted to cholesterol ester. Many of you might not understand why the cholesterol is converted into cholesterol ester form. Acylic ester, what is an ester form? It's an acid fatty acid, acid plus alcohol combo. What is the cholesterol? Is an alcohol. When you put along with an acid to it, it becomes an ester. Remember this, always whenever cholesterol is converted into cholesterol esters, okay, it takes up lesser space. Okay, it takes up lesser space and it is easy to load the lipoprotein with more amount of cholesterol. So the body has an inherent mechanism to take up more cholesterol by converting the cholesterol into cholesterol esters in order to create more space for more cholesterol. Point number one. Point number two, whenever cholesterol is converted into cholesterol ester, the transport efficiency is increased. So it is easier to transport the lipoproteins. So these are the two forms. These are the two main reasons why cholesterol is converted into cholesterol ester. And this cholesterol to cholesterol ester conversion is done by two enzymes. If it is going to be intracellular, it is done by an enzyme called as acyl cholesterol acyl transferase ACAT. If it is going to be extracellular, it is done by an enzyme called as lecithin cholesterol acyl transferase. It's an extracellular, intracellular. We got understood this. Okay, so now this storage now leads to a common cholesterol pool. This leads to a common cholesterol pool. And now I'm going to teach you what is the effect of this common cholesterol pool on the receptors, on the further cholesterol synthesis and other things, on like synthesis of cholesterol related products like bile acids, steroids. These are the cholesterol derived compounds. Okay, so all these compounds. So let us go. Yeah, so this is the picture. I've already simplified the process for you. Now I'm going to just explain it again. Just take it slowly and ensure that you all understood what I'm saying. Okay, number one, cholesterol intake. See here, this is on receptor pit. This is the coated receptor pit. I have already told you it is a clathrin coated pit. Clathrin coated pit. Okay, so either the cholesterol can enter as free cholesterol or it can enter as cholesterol ester. It can enter as cholesterol ester. So this is number one mechanism. So number two mechanism is scavenger receptor. Scavenger, the word is scavenger, something which is scavenging. Scavenging is takes it away. Okay. Number three, it can enter as free cholesterol. So these are the three methods in which cholesterol can enter. And once it enters here, it is going, it's either if it enters as free cholesterol, it will go to the common unesterified cholesterol pool. Common unesterified cholesterol pool. Okay. Or supposedly, if it is entering as cholesterol ester, what is going to happen is this cholesterol ester is taken to the endosome, and from there it is taken to the lysosome where it is digested to release the free cholesterol, which again, so it's endosome, from there to lysosome, cholesterol ester digested to free cholesterol, again enters the common cholesterol pool. Okay, and once the common cholesterol pool is achieved, I have already told you it has to be converted into cholesterol ester to create more space in order to accumulate more cholesterol. So this conversion is done by, since it's intracellular, it is done by ACAT. So we have cholesterol ester, but then cholesterol ester formation is a reversible process. Again, the cholesterol ester can be converted into free cholesterol by another enzyme called as cholesterol ester hydrolase. Cholesterol ester hydrolase. Okay, but don't worry about it. Don't worry about it. I'm just hoping to, you all understood this entire process of cholesterol being stored as free cholesterol or cholesterol esters. As simple as that. Okay. Now, once you understood this, let me be very clear. This common cholesterol pool is having a lot of roles. Number one, it has to supply for steroid synthesis. Number two, vitamin D synthesis. Number three, bile acid synthesis. All these compounds are derived compounds from cholesterol. Okay, but in the process, this common cholesterol pool also has a down regulation effect or a negative inhibition effect on two things. Number one, it inhibits the cholesterol synthesis per se. It's going to go and tell to HMG-CoA reductase, which is a rate-limiting enzyme of cholesterol synthesis. See, enough amount of cholesterol is already present in the tissue. You are not going to synthesize anything more. So let us stop it here. Don't undertake any more synthesis of cholesterol. So number one, it is going to decrease cholesterol synthesis. It is going to decrease cholesterol synthesis. Number two, it does not want any more cholesterol, which means that it is not willing to take cholesterol from extracellular to intracellular, or it says cholesterol should not enter from outside to inside. So it's going to tell what the normal process is happening is, once the cholesterol ester is digested, the cholesterol recycle vesicles which contain the cholesterol ester, they are recycled and they are going back to the cell membrane. They are going back to the cell membrane. So they are going to enhance or replenish the LDL receptors. Now this cholesterol pool, once it's high, it is going to stop. It is going to stop that. Tell them you are not going back. There is no need for taking up cholesterol. So there is going to be lesser number of receptors which are going to express at the cellular level. So this fellow has another effect which is decreases the receptor synthesis. So there are two effects for cholesterol pool. Number one, decreases cholesterol synthesis. Number two, decreases receptor synthesis. Hope you all understood that. So if you understood that, then you have understood everything. It's pretty much very clear. So how about the other side, the efflux side? I have told you HDL is mediating the efflux through two things, ABCA1 and SRB1 is another scavenger receptor, or ABCG1. Let us not worry about that. These are involved with the reverse cholesterol transport. From the cholesterol pool, whenever it is, the HDL cholesterol removes the cholesterol and it is going to go out of the cells to the liver. Okay. So again, three mechanisms: LDL receptor mediated clathrin coated pit intake, scavenger receptor mediated intake, direct pinocytosis, LDL enters into the cell. So whatever it is going to get converted into cholesterol ester. It is going to go to the endosome. From there, it is going to go to the lysosome. Digestion, free cholesterol is dumped into the cholesterol pool, and the recycled vesicle is going to go to the receptor to partake more cellular uptake of LDL cholesterol. So basically, the cholesterol is going to get absorbed, and then the common cholesterol pool is going to tell, no, I'm going to synthesize more cholesterol. No, I'm not going to intake more cholesterol from the extracellular cell. So this is a very, very highly regulated process. This is LDL receptor regulation, which is done by the common cholesterol pool. Now this can be read in chapter 26, page 622, Harper, International 31st edition, for the biochemical processes. Okay, for the biochemical process. But one thing you all should understand is, see, we have linked subjects. We have, just a minute. We have linked subjects like maybe anatomy. It will go in hand with surgery to go do the disorders, and then it will come back to pathology. So this is a cluster. This is a cluster. Okay. Likewise, the link subjects for biochemistry will go back to internal medicine, and it will come back to pharmacology. And then it will come back to pharmacology. Okay. So now, if you want to complete the process, it is not enough we stop with cellular mechanisms or the biochemical levels. You need to go back to the medical medicine and know the disorder, and then come back to pharmacology to know the treatment. Okay. Having said that, you need to go to medicine, which means this chapter is given in Harrison's 20th edition, chapter 64, page numbers 2895 to 2908. So this is the page where they'll deal about lipoproteinemias, and I'm not going to much detail about that. Basic consensus I'm going to tell you. See, the whole world agrees pharmacotherapy is needed when LDL level goes above 190 milligrams per deciliter. And the basic lipid lowering drugs, as such, as of now, you all know, number one, statins, HMG-CoA reductase inhibitors. HMG-CoA reductase. Number two is fibrates. They are basically for the triglycerides, gemfibrozil, fenofibrate, all those kinds of stuffs. And of course, there is niacin or vitamin B3, another lipid lowering drug. And then there is resins or bile acid sequestrants, which are cholesterol, acetamide, and cholesavalum. All these things, they are all put together in this group. However, I would like to discuss with you about three new drugs. Okay, three new drugs which are probably you are missing so far. Okay, maybe you have not heard of them. Number one, PCSK9 inhibitors. Okay, the drugs would be alirocumab, yavalocumab. These are the drugs, alirocumab, yavalocumab. And then there is another drug called as MTP inhibitor. MTP inhibitor. The drug is called as lomitapide. That's Lomitapide, lomitapide. And the third drug is a very molecular basic drug, which is an antisense ApoB oligonucleotide. ApoB oligonucleotide. That drug is called as mipomersen. 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 Okay. Now these two drugs, which is MTP inhibitor and antisense ApoB oligonucleotide, they were launched in 2012 US FDA as orphan drugs. Orphan drugs means any drug which is not commercially developed. These are called as orphan drugs. And PCSK9, it is developed as monoclonal antibody that can be taken for a period of 2 weeks subcutaneously. Dosages are given in page number 2908. I hope it is 140 starting dose for alirocumab and maximal 420, and for yavalocumab it is 75 milligram and maximal dose is 150 milligram. Okay, now let me tell you the mechanism of action of these drugs. Number one, the story about PCSK9 inhibitors is very much interesting. In African Americans, about 2.5% of the population had something called as an SNP loss of function. SNP means single nucleotide polymorphism, which affected the function of this PCSK9. So what is the basic function of PCSK9 is PCSK9 destroys the LDL receptors. Simple. PCSK9 destroys the LDL receptors. So if PCSK9 is not there, okay, PCSK9, let me write it so that you don't forget. PCSK9 destroys LDL receptors. So no PCSK9, no receptors. Okay. So sorry, more PCSK9 means no receptors. So no receptors means LDL is not taken from the outside extracellular into the cell, which means LDL uptake is not there. There is increased level of circulating. There is increased level of circulating LDL. There is increased level of circulating. Now these African Americans, 2.5% of them had a loss of function mutation of this gene. So there is no PCSK9, which means though PCSK9 is not there means receptors are not destroyed at all. They were not at all internalized. So more and more receptors means more and more uptake, and they had very less LDL. Some of them even had like 20 milligram per deciliter LDL. That's the minimum achieved, 20 milligram per deciliter. So this led to the hypothesis among scientists that if suppose we can inhibit the PCSK9, then it is going to help us a lot by lowering the LDL levels. That is because when you inhibit the PCSK9, the receptors are going to be expressed too much. The receptors are going to be expressed too much. More and more LDL will be taken up by the cells, and the increased clearing of the LDL from the bloodstream is going to result in lesser LDL levels and lesser pathognomonic side effects of LDL. So this is the mechanism, and I told you there are two drugs, alirocumab. See this monoclonal antibody. These are the two drugs. This is the number one class, PCSK9 inhibitor. Okay. Now, the second class is MTP inhibitor. MTP is microsomal triglyceride transfer protein. Point number one. Point number two, this is needed for assembling beta lipoproteins like VLDL, LDL, IDL. So when there is no MTP, there is not going to be any assembling of beta lipoproteins. So we come out with a compound which can inhibit this MTP. The mechanism is so intricate, I'm not going to go into so much detail about that. I'm just going to tell you the drug name. It is lomitapide. It is lomitapide. Okay. Again, launched in 2012. It's US FDA approved. This drug and the other drug, mipomersen, they are utilized only in United States of America and the European Union. Okay. They're not for sale here. Okay. Number three, this drug, mipomersen. Okay. Point number one, Antisense ApoB100 oligonucleotide. Pretty much simple. This is a molecule which can bind to the mRNA which codes for ApoB100 and inhibits it. Very simple. Antisense therapy is one of the mechanisms of gene silencing. Okay, so this drug is going to go to the mRNA which is going to code for ApoB100 and tell them, okay, I'm going to silence you totally. So this drug means decreased mRNA coding for B100. So that means there is decreased B100, decreased LDL. It's as simple as that. So this drug, mipomersen, launched by Agerian Pharmaceuticals. It's approved for treatment in United States of America as well as the European Union. So these are the new concepts that has come with lipoprotein metabolism. Always understand, whenever you reach the maximal dosage of all this when is maximal dosage of all the drugs which I have told you, you have reached maximal dosage and still you are stuck with LDL greater than 160 mg per deciliter. Okay, Harrison says there are only two options left. The first option would be something called as LDL pheresis. That is, it is like dialysis. You send the LDL rich plasma through a filter. Okay, the filter is going to remove the LDL, and the LDL filtered or LDL less plasma, it is going to be introduced back into the bloodstream. This process is much like plasma pheresis. Okay, it's like LDL pheresis. This is a treatment option. The last or final treatment options would be very easy. Liver transplant. Is a liver transplant. It's a final process, end process. Okay, so maximum everything you have tried, still LDL is greater than 160. It's gone. Okay, it's gone. Okay, so with this, I think so. I have explained you what is what LDL metabolism, LDL uptake, and how the LDL is regulated, and the pathology and the pharmacology and the medicinal part of LDL metabolism. I've taken LDL, that's because it is one of the significant and more deleterious molecule as far as cardiovascular side effects are concerned. And this entire branch is evolving as a subspecialty. And if you take MRCP courses offered in UK, the subspecialty of MRCP, chemical pathology. The chemical pathology is the equivalent for clinical biochemistry in India. So is metabolic medicine, and clinical lipidology is one of the subspecialty which is developing. So there's going to be a lot of more updates, and there's going to be a lot of more drugs by the time we are looking into a period of 5 to 10 years. Okay, so and now thank you so much, and I hope you all enjoyed this session. And I've leave the links in the comment section for the Telegram and YouTube channel, and the video is also uploaded in the YouTube channel. And please do leave your comments, your feedbacks, and any suggestions you want, or if there's any particular difficult topic you want me to address to, I'll be more than glad and more than willing to help you all. Thank you so much. Thank you, and have a nice day. Great. Bye.